All right, so I'll go ahead and go back to Tom. Can you kind of talk a little about what you think of some of the special risk factors that military have? Veterans, military, active military veterans and their families.
Sure. So the biggest one is when the draft ended in 1972, the military became kind of a professional organization, not that it wasn't before. And we've now had almost a decade of war, and there's a lot of trauma out there that needs to be addressed. And the interesting thing about that is that of those 19 to 20 million veterans and the million or so that are on active duty, there's a myth that they get all of their care through the VA or directly from the military. And that's not true. A lot of it is delivered in the civilian community by providers that, quite frankly, aren't prepared to address the unique situations of military service. So the main thing that I would say is they need to get trained. And the easiest way to do that is to attend sessions like this, and also go to the VA's community provider toolkit. And that's all you have to do is just do a Google search and community provider toolkit. And in there you'll find just a wealth of information about the military, about the factors that, the risk factors that they have, and probably a little too much, but you can pick and choose what you want to do. I don't know if that answered your question or not, Steve, but I kind of drifted a little bit there.
No, that's fine. Dr. Sobo, so, I know law enforcement has really, special issues that, and again, remember, we're here with a conference that has, basically medical personnel. And what should they be looking for if they see a patient that's, law enforcement, first responder in any way, actually? What are the special risk factors they should be asking about?
Well, first, I think it's important to have some familiarity with the job of law enforcement and what is normal versus abnormal in terms of depression, behavioral disorders, and any emotional issues that somebody that they are seeing or evaluating is expressing. Because many times our officers are fearful of talking about suicide, let alone depression or trauma, in fear that they might lose their job or what they say is actually going to affect their status on the job. And that is the first and foremost and primary concern of theirs, above their own well-being, believe it or not. So when talking to officers, I think there's a number of different things to ask. One is, where do you work? What is the district or unit where you work like? What kind of scenarios have you been in? Have you been involved in a trauma? If so, what was it? Were you seen in a mandatory debriefing? If so, how did that go for you, and where are you now in terms of handling or coping with that trauma? And looking for, the usual signs of how are you sleeping? How are you eating? Do you exercise? And, some awareness of the fact that, particularly over the past year, with all that is going on in the world, with the protests, some of the political challenges that we have, the injustices that we are all going through, and the fight for justice, including Black Lives Matter, is an important component to addressing with police officers to see where they are at and how that has impacted them.
And I'll add that those things also apply to veterans and active duty service members.
Yes.
One of the first things you want to do is find out, because you need to ask the question, have you or a loved one ever served in the armed forces, or are you currently serving? And you'd be surprised that, well, particularly women, they don't consider themselves veterans, even though they are. And so you need to ask that question, and that begins your engagement, understanding that that they have a history of being in the military, and whether or not they were deployed or not. Some service members have multiple deployments, 5, 6, 7 deployments. Others are new in the service. They're young. So some of the issues that you're having with mental illnesses are beginning to express themselves. And they may, through the stress of being in the service, that will cause some problems. And then the military hasn't been very good about taking care of them. They boot them, kick them out. And it's usually with a bad paper, some kind of a bad discharge. When in fact, if they had taken the time to realize what was going on with the individual and get them care. And on the other hand, they are about 60 to 70% that have mental illness problems or mental health problems don't seek care. And they don't seek care because, like Robert said, they feel that it's going to affect their career. When in fact, the command does not have access unless there's a real danger to the information. They can go to the chaplain, they can go to a mental health professional and be assured that the information that they share with them to get the help that they need is confidential.
Yeah, Dr. Sobo, what are some real concerns that police officers have about confidentiality? I mean, do they see the same issue with command being aware and repercussions, or their fellow officers?
They do. And, many officers, depending on where they come from, don't believe, regardless of what you tell them about confidentiality, that it is actually going to be confidential. And in those circumstances, what I personally try to do is talk to them about, well, what would happen, do you think, if you didn't continue to go for help? If you continue to experience these symptoms and display the behaviors that you are, what do you think might happen if other people are noticing it? Because really, the one way for you to continue to have control over your well-being is to make the decision to have it and to take all steps necessary to preserve your well-being or to get to a place where you do have it. And that's something that they can, resonate with and understand, because the last thing that they want is to be out of control. And if you frame going for treatment as an option that they have to actually take control, then it gives them a lot less anxiety in going forward and actually choosing voluntarily to be in treatment or counseling.
Absolutely. I agree with that.
Yeah, Tom, one of the things that I'm thinking about is peer support. I mean, that veterans, are a definite peer group. Do you see veterans, informal groups, not through the VA, but, groups that you're aware of that can provide support to each other?
Yes, they're, they have different terms for it, and depending on the service. Battle Buddy is one of them that the Army uses. Dry Hooch is an organization that starting a new venture with here in Illinois. And Dry Hooch is what that is that's a peer mentor, peer support organization. The peers are critically important to have someone that is understanding what's happening with you. There's a story of a guy being in a hole, and everybody comes along and tells him, get out of the hole. The sergeant, the lieutenant, the doctor, the chaplain. And then along comes the guy that jumps down in the hole with the other guy and says, I know what you're going through. I can help you get out of this hole. And so you need somebody that can, relate to what is occurring with the individual. And that's the best way.
Dr. Sobo, are there
Yeah.
similar peer support among law enforcement?
Yes, law enforcement are, highly recommended by the International Association of Chiefs of Police to have peer support programs. And in the Chicago Police Department, under our EAP, we have a couple hundred peer support members, and all of their bios, all of their pictures are up on a website so that our officers can look through them or call us and say, here's what I'm going through. And we can connect them with somebody who has a similar experience, whether it be losing a child or having been in a shooting or having felt suicidal and come out at the other end. So while we're seeing them in treatment, we hook them up with a police officer who's been in treatment, been in that shooting, lost a child, and is, a model of survival and can help them through it and give, great support in a way that nobody else can, while they are seeking treatment from a professional.
Tom, you mentioned that, actually a fairly small percentage of veterans are actually receiving medical assistance through the VA. How come? What's the difference between them and the others that get the service?
So the difference is that in order to receive care from the VA, you have to have a service-connected disability of some kind and have to be rated. And not everyone has that. That's why when a provider encounters someone, they need to know that they should reach out to the VA and have the individual, because this issue that the individual is having may in fact be service connected. And that way they can receive compensation and also be eligible for care. Of the 20 or so, the number has been fluctuating, of veterans that die by suicide. I think it's 14 of them, 6 of them are with the VA, the other 14 are not. And so the VA has taken the approach that they can't do it all by themselves. And so that's why they're reaching out and forming these relationships in the civilian community through educational specialists and suicide prevention coordinators across the country to build relationship with the civilian community, so that this public health approach that they're working on with veterans actually helps everyone.
Are there, there's certainly a military culture. Is there a way for, medical behavioral providers to get some sort of training education in that culture?
Sure. That I'll refer you back to the military provider toolkit, or the community provider toolkit. Just Google that, community provider toolkit, and it will take you to the VA's training modules. And then in this governor's challenge that we're working on, where the VA and the Division of Mental Health will be providing training to providers in the state as well.
Yeah, let's back up a second on that governor's challenge. Why don't we introduce that to the audience and let them know what this is about?
Sure. So the Veterans Administration in SAMHSA uh, uh, offered Illinois to participate in what is known as the Governor's Challenge. And the purpose of the Governor's Challenge is to prevent suicide among service members, veterans, and their families. There are currently 27 states that are participating. And last year, we spent quite a bit of time going through, quite frankly, a mini boot camp on suicide prevention provided by SAMHSA, and over basically a 3-day period. And we developed 3 priority areas for addressing suicide prevention. The first one being identifying veterans, service members, veterans, and their families, and screening for suicide risk using the Columbia scale. The second is connectiveness and improving transitions, care transitions. And the third is lethal means safety and safety planning. So those 3 are the action items that we developed. There's a lot of individuals involved, a lot of organizations involved. We didn't touch everybody, but we're going to, because we're getting ready to start an implementation academy here in the next few months. And in that, we will draw a lot of the organizations that we didn't reach before in. Separately from that, SAMHSA offered the Peoria area the opportunity to do crisis intercept mapping. And we're going to be starting that as well. So we're kind of busy.
Dr. Sobo, I know, particularly after the Justice Department report back in 2019, I think, they did recommend that the Chicago Police Department upgrade its SelfCare for officers. So, what have you been doing to implement that report, and particularly as it applies to suicide?
Sure. Well, one of the things is, of course, having a sufficient amount of staff that are easily accessible. And, before the DOJ report, we were really only able to go to tragedies or respond to crises as they occur. Now with a larger staff, we're in front of it. And by in front of it, I mean that we are placing, wellness as something that is a practice that our officers do every day. And it's under the framework of, officers check and make sure that all of their gear is in working order every day to make sure that they can survive, whatever it is that the call may bring about when they experience it. Well, if they're going to check that every day, then they also need to check and make sure that what's going on with them emotionally is intact, because of course, your mind and your emotions control all of the decisions, all of the judgment, all of the speed, accuracy, that you have. So suicide prevention in the police department is about practicing wellness every day, because if we are only learning about signs and symptoms of suicide, then we're too late. We're not doing our job. We want to make sure that as stresses or traumas come about, that our officers learn to identify them for themselves and each other, and do the responsible thing for themselves, their peers, and also their family members, and go for intervention support, counseling or debriefings when it comes up, just like they would if any of their weapons or any of their gear isn't working order. They would go and make sure that that was fixed. Well, the most important thing to take care of is your emotional well-being, because that affects the rest of what they do.
Now, has COVID-19 affected your ability to implement these programs?
Well, it's been somewhat more difficult in that we can't do, when we do debriefings, we don't do large group debriefings because it's, of course, not safe. But our officers do need to be seen, one-on-one. They need that contact. They need a person sitting across from them. So it's been more difficult, but we certainly, have to provide them with whatever means that they need, while also, of course, making sure that it's done safely. And certainly since COVID, we've had an increase in suicidality, in drug and alcohol abuse, and in trauma because of the fear and anxiety, not only of getting COVID themselves, but bringing it back home. So one of the things that's going on right now for a lot of our officers is they're struggling alone in their own minds with all of these fears and anxieties. So teaching them how to cope during this, extraordinarily difficult time is also crucial. So we are out there talking to them through roll calls and debriefings and trainings about, how COVID may be impacting their well-being and their families, and how to manage that so that they don't wind up, getting into a bad place that puts them in somewhat danger.
We had a previous session on access to lethal means, for firearms. Kathy Barber was really talking about, safety protocols for firearms. Dr. Sobo, how can you do that with police department that obviously they have to have a firearm and they can't lose their access to it?
Right. So if a Chicago police officer loses, if their weapon is taken away and they're stripped, then they lose their FOID card. So part of what we do when we assess officers is do a real assessment in terms of, are they suicidal? And, suicide to me is different in each individual and takes a lot of different variables into consideration. For example, if we were to take their weapons informally, like have a supervisor hold it, or an officer that is assigned to the EAP or our peer support program hold it, is there another way to keep them safe that might not threaten their job? Because frequently when officers are afraid that their weapon's going to be taken in a formal way, that they might lose their FOID card, sometimes you actually might be increasing the risk of a successful suicide or a suicide attempt soon after your risk assessment. So it's pretty complicated, but it has to be done thoroughly and preferably by somebody who works in law enforcement and has some expertise in dealing with these issues and understands the impact of losing the FOID card. Of course, that being said, nothing's more important, and you do whatever you need to do to preserve the welfare and the safety of a human being, because it is just a job and there's no opportunities if you don't have your life.
Right.
Now, this session's going to end in 5 minutes. So if there's any questions, please try to get them in now.
Steve, there are a couple out there. I just pulled them up, and I want to address the one comment from Jess.
Okay, good. I was going to read that one if nobody else had a question. Go ahead, Tom.
Sure. So I guess what I was talking about was the vast majority.
Let me read the question. People don't.
Oh, I'm sorry. Go ahead.
Yeah. So Jess, who's with the VA, I would like to clarify that you do not need to be service connected to receive care through the VA. Many veterans receive care who are not rated for disabilities. The reasons are vast and nuanced as to why a majority of Illinois vets are not eligible. Okay.
Right. And Jess is right. If a veteran feels that they need to be seen, they can go to the VA, and the VA will engage with them and help them. But when they do that, they need to go through the process of determining whether or not they do have a service connection. And the VA has, in fact, the vet centers were created because Vietnam veterans weren't happy with the VA you know, they kept running into unfriendlies, so to speak. And so the vet centers are out there, and they will take individuals and provide counseling for them. And you don't have to sign up and, you know, get yourself determined whether or not you're service connected or not. I hope that answers the question that yes, you can receive care through the VA and you don't have to be actually rated. Then the other question there was, what is the reference that I used for finding out information? And that is the Community Provider Toolkit. And that is available just through a Google search.
All right, we have another question. Actually, it's not in our Q&A, but I have a message here. What needs to happen on a policy and systems level to ensure that those who serve our country get the mental health care that they need?
Wow.
Yeah, that's a we can have a whole conference, I think.
Yeah.
A miracle?
A miracle. Right. Well, let's be fair. You know, when the military does something and they put their shoulder to it, you know, they do quite well. There's tremendous programs already in existence, and they start as soon as somebody enters boot camp, and they go all the way through a career when someone leaves the service. Every service has its own programs. The DoD has its Department of Defense has a program that are there to help service members, veterans, and their families. And then in Illinois, there are like 500 nonprofit organizations that have some type of a veteran program. Across the country, it's over, you know, almost 47,000. So it's a sea of goodwill out there, as one of the Joint Chiefs called it, that have organizations willing to help people as long as they know what they're doing.
All right, well, our time is up. So Dr. Sobo, thank you for joining us. And
Thank you.
Commander Miller, thank you for your service, and thank you for joining us today. And
Thank you, Steve.
Be safe. Take care.
Yep.
Gentlemen, thank you.
Bye-bye.
And,
Bye-bye.